Getting Paid for What We Do Best, sponsored by the American Academy of Family Physicians, recorded on March 10, 2017. My name is Karen Breitkreis, and I'm a delivery system strategist for the Center of Healthcare Finance and Delivery at the AAFP. I will serve as your moderator. Out of respect of your time, this presentation will be 50 minutes. Here is the disclaimer for your review. And now on to today's speaker. It is my honor and pleasure to introduce to you Dr. Lisa Bailey. Dr. Bailey, originally from Texas, is a graduate of the Houston Baptist University and Baylor College of Medicine. She did her family medicine residency at Elgin Air Force Base Regional Hospital, and after serving at Tyndall Air Force Base and in Saudi Arabia during Operation Desert Storm, she opened a solo private practice in a small Florida panhandle town of Bonifay, Florida. She and her husband, James, raised their family in Bonifay, where she has been in practice for over 20 years. She enjoys practicing the full spectrum of family medicine, including pediatrics, obstetrics, geriatrics, and emergency medicine. She also enjoys teaching the many medical students that rotate through her office from Florida State University and the University of Florida. While Dr. Bailey has done chronic care management for years, she has over the last 2 years instituted a formal chronic care management program in her office. Whenever possible, she enjoys sharing the success of the program she has brought her practice with other physicians. We are pleased to have Dr. Bailey present for us today. At this time, I will turn the presentation over to Dr. Bailey.
Thank you, Karen. Let's get started and talk a little bit about chronic care management. What we're going to be talking about today is a formal chronic care management program. I know that most of us do chronic care management as a part of our practice every day, but this is the CMS Chronic Care Management Program, and we're going to talk about CMS's requirements and summarize some of the visit elements that they do require. We're going to identify how CCM, or chronic care management, can manage our patients' chronic conditions, how it can close care gaps, and engage our patients in their own care. We're also going to assess the financial and the quality implications of using CCM as a means of practice improvement. And we're going to talk about the importance of CCM in relationship to the value-based payment systems that are upcoming. Finally, for those of you who are already doing CCM, we're going to talk about some of the real and important changes for 2017. First, let's just talk a little bit about chronic care basics. We need to know what a chronic care management program is, what its requirements are, how do you implement a program if you haven't already, and what are some of the barriers and the benefits to chronic care management. There are requirements in order to bill and to be reimbursed for chronic care management under CMS. And the things we need to know is we need to know who's eligible, what is required of us in order to bill for those services, whose time counts and how do we document that time, and how do we get paid, and how do we avoid billing pitfalls. The most important question is who is eligible. Well, first, anyone is eligible to be in a chronic care management program, but only certain patients are eligible for reimbursement for that program. Medicare patients who have at least 2 chronic medical problems are generally eligible. Those problems are expected to last at least 12 months or until the death of the patient, or those problems are expected to place the patient at significant risk of either death or acute exacerbation, or functional decline. When you get right down to it, it includes most chronic medical problems. And when you think about it, most of our Medicare patients have at least 2 chronic medical problems. There are a group of Medicare patients who are not eligible, and that is patients who are our residents in nursing homes and in assisted living facilities who receive money from Medicare. Those patients cannot be in our chronic care management program. This is a list of some of the chronic conditions that CMS actually lists on their site as being eligible for chronic care management. This is not an all-inclusive list. This is just examples. As you see, it's most of the spectrum of chronic conditions, including dementias, arthritis, asthma, COPD, cancers, depression, diabetes, heart failure, hypertension, coronary artery disease, and osteoporosis. And again, There are many other conditions that would fall within the chronic condition requirements for chronic care management. This is only a few of them. And so what do we need to do in order to bill for chronic care management? Well, the first thing is you have to be able to provide 24/7 access by telephone to your patients. Most of us do that already, and so that's not a difficult thing to implement. They also ask that you have a secure email. That is one of the things that we did not have in my practice when we started doing chronic care management, but it was a very simple thing. We contacted our IT folks. They were able to set up a secure email for about $35 and maintain it for $5 a month. And that secure email has actually been very useful, not just for our chronic care management patients, but for all of our patients. Number two, you have to be able to coordinate referrals and transitions. Again, that's what we as family physicians do very well. We make referrals for our patients. We make sure we get the referral notes back. When our patients are discharged from the hospital, we follow up. We make sure they come in to see us after discharge. Those are things that usually we're already doing. Number three, provide timely appointments as needed. Again, I think most of us are already doing that. Number four, you have to provide periodic medication reconciliations and preventive services, like immunizations and screenings. And honestly, that's one of the things family practice physicians do best also. I will tell you this, I thought I was doing a lot better job at this than I actually was. When I started doing chronic care management, I realized that I had a lot of care gaps and that my chronic care management program helped close those gaps. Number five, if you haven't seen the patient in the last year, you have to provide either a wellness visit, a welcome to Medicare visit, or a comprehensive office visit prior to initiating the chronic care. That's just one of your 99213 or 99214 regular evaluation management visits. And that's only if you have not seen them in the last year. Number six, you must have consent from your patient to initiate the services. That consent does not have to be in writing, but you do have to document it in your chart. Number seven, you have to develop a comprehensive, personalized chronic care plan for each patient. You create it and you revise it and update it as needed. That is one of the elements of chronic care that we were not doing prior to implementing this program. Number eight, all members of your chronic care team, that may be you, a nurse practitioner, it may be other physicians, it may be your RNs or LPNs or medical assistants in your office, but all of those members of the chronic care team must be able to access that care plan in a timely manner. Number nine, you have to provide the patient a copy of their chronic care plan. Number 10, you have to use some sort of certified electronic health record technology. You have to be able to share your care plans. You can either share it through your electronic healthcare technology, or you can share it through fax. And you have to be able to communicate with patients by phone or that secure email. That's a change for 2017 also, the ability to share those plans by fax. And then finally, you must spend at least 20 minutes of non-face-to-face time each month. And we're going to talk a little bit more about what that non-face-to-face time includes. So let's talk a little bit about documenting time. That's very important, and you have to get your staff on board with the fact that every time they do something that is over the phone or that is a non-face-to-face piece of work, they need to jot down how much time they spent doing it. And I'm going to do this slide a little bit backwards and jump down to whose time counts. And it's important to know that all members of your clinical team get to count their time toward chronic care management. That includes yourself, the doctors, AR&Ps, PAs, nurses, both LPNs and RNs, and it also includes medical assistants or clinical office assistants. The only people whose time does not count are clerical time, such as receptionists calling to remind people of appointments. That time does not count. And what time counts? Every minute that you spend either reviewing labs, x-rays, consultant notes, those all count. Anytime your nurse spends arranging referrals or speaking to home health nurses, or if you speak to home health nurses, that time counts. Time answering patient phone calls and emails about their chronic conditions, and now even some of their acute conditions as well, that counts. and any telephone education that is done that month, either by yourself or by your nurses, counts. In fact, the only time that really does not count is time that's actually spent on the same day as an office visit. CMS expects that any time you spend doing referrals and doing outside operations on the day that you actually saw the patient should be bundled into that patient's visit. And you can see, since all of this time counts, how important it is that everyone in the office gets on board with documenting their time. When you review a consultant record, you either quickly pencil in how much time you spent on the edge of that report if you're doing it on paper, or you type in 5 minutes, 4 minutes into your electronic medical record if you're reviewing it on an electronic fashion. So how do we get paid? Well, in order to get paid, you have to bill a procedure code, and you have to list the diagnosis, and you have to send in the bill. And the procedure code is pretty easy. The most common procedure code that we use is that first code, the 99490, and that's for basic chronic care. The codes that you see after that, the 99487 and 99489 and the G0506, those are new codes for 2017, and I'm going to talk a little bit more about them later, but those include complex chronic care and also a chronic care initiation code. The diagnosis codes generally will be the 2 chronic conditions that qualified them for chronic care. You can definitely list more than one, but those 2 need to be on your bill. And then the best way to batch this is to send the bills at the end of the month. You can actually send a bill as soon as you have logged the 20 minutes of required time. So you could theoretically be sending these throughout the month, but it makes more sense to send them all at the end of the month. Number one, you can track them, send them all in together, see how your reimbursement is coming back very easily that way. And then number two, since they have these complex codes now, if you billed for a 99490 after logging 20 minutes and then you wound up logging 40 more minutes, you would miss out on billing one of the more complex codes. So we recommend billing at the end of the month. And when can we not bill? Well, if you're doing transitional care for a patient that month and it overlaps with your chronic care, you should not bill the chronic care. The transitional care is a better reimbursable code, and if you bill them both and they overlap, then they probably will not reimburse either. Now, there is one exception to this. If, for instance, you had a patient that was in the hospital from, let's say, February 2nd to February 4th and was discharged on February 4th, and then that patient received transitional care, and that transitional care period ended on March 4th, 1 month later, and you still had time after March 4th to log your 20 minutes, you could conceivably bill the transitional care and the CCM care in the same month. Just be very careful that they don't overlap. Another situation where you cannot bill for chronic care is if you're billing for hospice oversight or home health oversight on a specific patient. You cannot bill for that patient for chronic care as well. The way we have managed that to keep it from being confusing is we bill only for chronic care. We do not bill for hospice oversight or for home health oversight anymore. We, for all of our Medicare patients, we just bill chronic care. If your patient's in a nursing home or in an ALF that gets compensation from Medicare, you cannot bill chronic care. And of course, if you don't document at least 20 minutes of chronic care services, you cannot bill. So how do you implement a program? Well, I'm just going to tell you a little bit about the way we implemented ours. We started in January of 2015 when chronic care began. And we did not send out mass flyers to all of our Medicare patients like some practices do, and that is one way of doing things. But we decided to sign up our patients as they came in. And so anytime a Medicare patient came in, we basically signed them up for chronic care. But there are three aspects to implementing it, and the first step is the sign-up period. The second step is developing that personalized chronic care plan. And then the third step involves probably the most important member of the chronic care team, and that's the designated chronic care nurse. So we're going to just go into each one of those steps a little bit. So the patient sign-up. I mentioned that we signed up everyone, and we did try to sign up all of our Medicare patients. Even the patients that did not necessarily qualify, if they were Medicare, we signed them up because we knew that eventually probably all of them would qualify. And so we went ahead and did the sign-up process. We let them know that some of them might not be eligible and that they still had access to us for the 24 hours, 7 days a week. We still gave them the phone number to contact us with. So really, we are providing chronic care for all of our Medicare patients, but we let them know that only if they qualified for the program would they be getting phone calls from the chronic care nurse on a monthly or as needed basis. And so all of our Medicare patients were really kind of excited about the program. In our office, the physician and now AARP also explains the program to the patient and answers any questions. Your nurse or medical assistant could also do this, but we just find that it works better and the patients are more open to it if the physician is explaining it. The patient fills out a health concerns questionnaire, and if needed, the staff will help them do that. If not, they fill it out on their own. And that's a very important part of this, because one of the things as I was developing these personalized chronic care plans that I realized is a lot of times my biggest concerns were not my patient's biggest concerns. I might be very concerned about their diabetes and their congestive heart failure, and their biggest concern might be having enough energy to go to church the next Sunday. And so this really gives us an opportunity to see what our patients' concerns are and really practice more of a patient-centered medicine. Finally, I reviewed the questionnaire and initiated the care plan. I do not develop the entire care plan in front of the patient. I basically sit down, look at their chief problems, and give them an idea of what we're going to focus on. It may be diabetic control. It may be recognition of symptoms of COPD exacerbations. And we talk a little bit about that, but then I generally go home and that evening review their chart, see where their care gaps are, and come up with their plan. And I have a template for that plan, and it really does not take a whole lot of time to do that. And on the physician reviewing the questionnaire and initiating the care plan and going over everything with the patient, that step is only strictly necessary if you're going to be billing this new G-code, but I think it really works out well for the physician to sit down and talk to the patient about the chronic care program. Finally, we tag enrollees in the medical record. If they are actually eligible for the chronic care plan, we have a little tag for our chronic care. It's a blue 4 that goes in the edge of each electronic medical record. And when I'm seeing patients and I pull up their chart, I know immediately that they're part of our chronic care plan. And so what we can do is, after I see them, if I want the chronic care nurse to follow up on anything specific, I can send a message to the electronic medical records to her as well. So how do you sell that chronic care plan to patients? Because a lot of times patients are suspicious of a new program. These are some of the selling points that I use with patients. I let them know that this is a new program designed to keep them out of the hospital, to allow me time to take better care of them. I let them know that it'll be providing 24-hour access to their healthcare team, and they should know that already, but a lot of them don't. I let them know that we're going to be providing more telephone medicine when possible and visits when they need them or want them. I let them know that CCM may decrease the frequency of their regular visits if they want it to. Some people don't want it to decrease the frequency of their regular visits, but some people would much rather come in every 6 months and then get phone calls in between than come in every 3 months. I also let them know that if they have a supplemental insurance or on certain ones of the Medicaid programs, that this program will be absolutely free. There are a percentage of my Medicare patients that do have a small copay, and I let them know that they may have a small copay. But I also let them know that fewer visits and fewer hospitalizations will more than make up for that copay. So now let's talk a little bit about the personalized chronic care plan. In 2017, the rules for this plan is that it may be created by the physician, the ARNP, the PA, or the chronic care nurse. And the rules have really been relaxed a lot, too, in terms of the specific requirements. But the things that I recommend being that chronic personalized care plan is a problem list with each of their medical problems and some specific measurable goals for specific chronic conditions. For instance, if I have a patient with diabetes, a goal might be for them to maintain an A1C less than 7, or depending on their medical problems, less than 8. And another goal may be for them to be able to recognize the symptoms of hypoglycemia and know how to treat them. And then I go right down the line with each one of their chronic problems and set a couple of measurable goals for each one of their problems. I include the patient-populated personal goals that they listed on their questionnaire that they filled out. I also have a list of all of their providers that I can easily access if I need to, as well as community resources like if they have a home health agency or if they utilize Meals on Wheels, etc. Also identify any care gaps. I go over all of their health maintenance. If they need a mammogram or a pneumonia shot, I basically list all of the things that they need on that care plan. We talk about medication management. I basically list all of their medications, and those are reviewed periodically by the chronic care nurse and reviewed with the patient by the chronic care nurse. We mail the patient the Welcome to Chronic Care letter. They have to receive that before we start billing for services. And generally, the makeup of the personalized chronic care plan generally takes me about 20 minutes, and it fulfills the requirement for the first month chronic care. Finally, let's talk about the chronic care nurse. The chronic care nurse, in my opinion, is the most important part of the chronic care team. She is the one that answers our patients' phone calls during office hours. Our chronic care nurse has a little headset where she can walk about the office doing her regular job, but where she answers their phone calls immediately. She reviews the labs. She reviews referral notes and x-ray reports and brings anything to my attention that is significant. She coordinates care between other specialists, and she makes referrals. She reviews the patient's charts each month for completeness of their health maintenance items, and she periodically does telephone medication reconciliation as well. She is also the person in our office who is responsible for transitional care and follow-up after both emergency rooms and visits and hospitalizations. She will make the phone callbacks as requested by the physician. If there is a patient that comes in and we want to check on that patient, all we have to do is send her a little message and she will make those callbacks. And when indicated, she will do some telephone patient education. We've had very good luck with things like smoking cessation over the phone, where the chronic care nurse has called the patient not just once a month, but once a week while they are trying to stop smoking. And we've had several elderly patients who've smoked for in excess of 40 years who've stopped smoking. Finally, she will carefully document the time that she spends for each of those activities and tally that time at the end of the month and then submit it for billing. And rarely is she not able to tally at least 20 minutes. So how do you fill the time if she hasn't spent 20 minutes in referrals or in reviewing records? Well, one of the things that she will do if she hasn't spent 20 minutes in referrals and records is she actually tries to call that patient every month as well. And let's say she had spent 10 minutes that month reviewing records. Well, when she makes her phone call, she will spend probably at least 10 more minutes doing patient education for one or more of their chronic problems. She'll address any health maintenance issues. If they have not had their flu shot, she'll get them in for their flu shot. One of the things that we have our medical assistants do, and they log their time as well, is we usually have a topic of the month. For instance, in the fall, one of those months will be flu shots, where the medical assistant will call every chronic care patient and tell them the flu shots are in and ask them to come in and get theirs. And we usually do that before we release our flu shots to the rest of our practice. We get all of our chronic care patients in. One of the things that I was not expecting that came up with chronic care is a little bit of provider conflict. And this isn't a big problem because not very many people are doing chronic care management. I'm not sure why, because it's a wonderful thing to do, but it has caught on with folks that know people who do chronic care. And what has happened is some of the specialists have started doing chronic care too, because a lot of them have a lot of Medicare patients, and they have realized basically how profitable chronic care is. And so just a personal example, I have a friend who's a pulmonologist, and I had told him how wonderful chronic care was and how well it was working in our practice. And I guess he took it to heart, and I went to sign up some of my Medicare patients and was told, oh, Dr. So-and-so has already signed me up for that program. And I had to basically get on the phone and talk to him and say, Dr. So-and-so, I really appreciate all you do for my patients, but I'm their family physician, and I'm best suited to provide chronic care for them. And it's very important, I think, for family practice and internal medicine, the primary care providers, to be providing this service, because we're the ones that knows the patient the best and are referring them to different specialists. So if the specialists in your area are signing up patients for chronic care, I would recommend that you very nicely let them know that these are your patients, and if necessary, remind them that we usually get to choose who we refer to. And he was very nice, and he stopped signing up my patients. And I would also say, though, that if you're not doing chronic care, then you can expect that one of your specialists will probably start signing up your patients. And that's another reason why it's important to sign up all of your patients as early as possible, because Medicare will not allow more than one physician to be doing chronic care for a patient. So what's new for 2017? Well, we've got several new codes, and that's a good thing, and we've got a lot less requirements, and that's a very good thing. So let's just review the codes. We talked about the first code, the 99490. That's the original chronic care management code. It requires 20 minutes of non-face-to-face time. And the average reimbursement for that code is $43 per month if you do the 20 minutes that month. Any month that you do not do the 20 minutes, you cannot bill that month. The new codes are, first, the 99487 code. This is for complex chronic care management. This requires 60 minutes of non-face-to-face time, and it requires moderate complexity in decision making. And what that means is it's just like with our evaluation and management codes. It means that something has changed in the patient that requires you to either update or revise their care plan, to make some changes in their treatment, and basically it requires you to think a little bit. And if that is present and you spend 60 minutes, and of course if you spend 60 minutes, that's almost always going to be present, then you, instead of billing the 99490, you can't bill both. Instead of billing the 99490, you bill 99487, and that's going to reimburse at an average of $94 a month instead of the $43 a month. And then the 99489 code is an add-on for each additional 30 minutes that you spend. So if your nurses wind up spending 2 hours in a month on a patient, then you will be billing a 99487 code for the first 60 minutes, and then you will bill the 99489 code twice more, and they will reimburse for all of that. And then this is a code that I really like. This is a new procedure code, and it's a G code, and it's for initiating chronic care. And this is something that I did before they had this code and just was not reimbursed for it. But this is a code that is an add-on procedure code to the visit that they're already receiving. And all it requires that you do is talk to the patient about chronic care, explain to them the program, talk to them a little bit about the personalized chronic care plan that you're going to be providing for them. And if you spend some time sitting down with the patient and telling them about chronic care and initiate the chronic care during that office visit, you can add on this code to your office visit. It's not in place of, but it's an add-on. And the typical reimbursement for this code is $64. The way we do this in my office is we try to do this code along with the yearly wellness visit. I schedule an hour for a wellness visit, and we do everything during that wellness visit. And we have multiple add-ons during that visit. We do smoking cessation. If they need a pap smear, we do that. We do depression screening, and basically we have lots of add-ons, and that is a very comprehensive visit, along with your end-of-life counseling, etc. And so this is a nice add-on during that visit. If they're not already signed up for chronic care, that's when we sign them up. So let's talk about some of the relaxed requirements in 2017. And this is a very unusual situation that CMS is actually relaxing requirements. And the reason that they've relaxed the requirements is because they want more people to participate. And one of the requirements that they've relaxed is the written consent is no longer required. It was required in 2015 and 2016, but it's not now. You still must document at least a verbal consent, but you do not have to have the patient sign anything. The second relaxation is the requirement for electronic transmission of the care plan. This is no longer necessary. Too many physicians had a hard time electronically transmitting care plans because we all have different electronic medical record systems, and it's very difficult. Now faxes are allowed. After-hours access to electronic medical records is not required. We actually have after-hour access at my office, but a lot of people don't, and it's nice that that's not required anymore, especially in a small practice when if you are basically a solo practice, then you're basically the one that knows your patients anyway, and so that's not as necessary. Finally, there used to be an initiating visit that was required. That's not necessary anymore as long as the patient has been seen within the last year. And of course, most of these patients have been seen within the last year. And the care plan requirements used to be very detailed and very specific. Now they pretty much leave it up to you. So what are some of the barriers to chronic care management? Well, I'm happy to say that in 2017 there are a lot less barriers when it comes to technology. The only thing that's really required is that you have that phone access and a secure email, as well as some sort of certified electronic health care record technology. Basically, all of the other technology requirements have been dissolved. One of the barriers is your staff, and it is very important that you get your staff on board with this. Nurses will be very nervous about a program that they do not have experience in. They will be worried that they don't have the time for any more paperwork and any more phone calls that they've been doing. I will tell you that in our office, the only thing that is a change to what they were already doing is the phone calls that they're making to the patient and the reviewing each patient's chart for all of their health maintenance each month. And that does take a significant amount of time. And if your nurses are already busy, it will probably require hiring either a medical assistant to take on some of the nursing responsibilities or hiring a specific chronic care nurse. But that's fine because they pay for themselves and you have more than enough compensation on the chronic care reimbursement to pay for a nurse or more than one nurse. Payment concerns. A lot of folks are afraid they're not going to get paid. I can tell you from month one, we got paid for almost every single claim that we submitted, and we are continuing to get paid extremely well. And then there's the potential disruption to your workflow trying to enroll patients, and that is a very valid concern. We have basically solved that problem by trying to sign up everyone during those annual wellness visits, although occasionally I will sign someone up during the day, also just during a regular visit or during a new patient visit. I do a lot of sign-ups. When I do that, a lot of times I will quickly explain the program to the patient, and I will forego that new G-code and have my staff come in and complete the process. With the patient, probably the two biggest barriers are the copays, and I'm hoping that eventually CMS will drop that copay requirement. And then the other thing is not wanting to answer the phone. A lot of our elderly patients just don't like to answer the phone, and sometimes nurses have to call and call and call before they will answer. That's not all of them, and once they get used to it and recognize our number, then they usually do answer the phone. And then the distrust of a new program. And like I mentioned earlier, by us explaining that program, if they've been your patient for a long time and they trust you, if you explain the program to them, you can usually overcome that barrier as well. So, what are the benefits? Well, in my practice, there have been multiple benefits, both benefits to the patient, physician satisfaction benefits. The financial rewards have been extremely good. And then better patient care is another very important reward. So let's talk about what the patients like. Well, they like that 24-hour access. If your patients are like my patients, at least my Medicare patients, you don't really have to worry about being bothered by your Medicare patients at night. These are the patients that honestly hate to bother me, hate to call me. And I actually have to beg some of these patients to call me. They won't call me when they're sick, and a lot of the education process is to let them know it is okay to call me if you have COPD, if you start wheezing on the weekend, please call me. I would rather you call me and me take care of you over the weekend than me have to admit you on Monday morning. And they do get to where they really appreciate that 24-hour access, and they do not abuse it, and it does not cut into my family time at all to answer phone calls for my Medicare patients. They like the timely appointments. That's something, like I said, we were already providing, but they just like the knowledge that they're going to be able to get an appointment when they need one. They actually like the less frequent appointments. And a lot of these folks, it's hard for them to get out of the house. Some of them, it's hard for them to get from the house to the car. And so if we can do more telephone medicine, they like that a lot. And then they feel special and well cared for when they're getting these phone calls every month to check on them and see how they're doing. The nurses get to know the patients very well too, and that's a big benefit. Physician satisfaction, I will tell you that I love my practice since starting chronic care, and I love it for a lot of different reasons. I used to think that I did a wonderful job at health maintenance. It was not until I started creating these care plans and checking each patient's health maintenance and seeing how many pneumonia shots were missed and how many colon cancer screenings were missed that I realized that I did not do as good a job as I thought I did. But this chronic care management helps change that, and our patients' health maintenance is being done much better. And that plays right into the value-based reimbursement system that is coming around the corner, because all of our patients' little boxes are getting checked off, and that will be reflected in that value-based reimbursement. Less hospitalizations will also be reflected in value-based reimbursement. And this is probably the biggest benefit to me. Before starting chronic care management, I kept a census of an average of 4 to 5 patients a day in the hospital. Now, it is not unusual for me to go an entire week without a patient in the hospital. And I feel like I've got a heavy load if I've got 3, and I rarely have 3. And I truly believe it's because I'm keeping these patients out of the hospital. My COPDers are getting treated for their exacerbations on weekends and at night, and they are not going into the emergency rooms. Number three, I've been able to hire more staff. And even when you hire staff for chronic care, they tend to be used for other things. And a chronic care nurse is also a very good PRN nurse to fill in when one of your nurses is on vacation, because they know your patients. And if you have a small practice, you know how difficult it is when a nurse is sick or a nurse is on vacation. And so we have actually added more than one staffer since we started chronic care. In fact, when we started, I told you we signed up people as they came in. So our first month we had about 40 chronic care patients, and one of my regular nurses was doing that. The next month we had signed up another 40, and we had about 80. The next month we signed up another 40, and we had about 120. And then my chronic care nurse started getting a little overwhelmed. At the time, I had a nurse practitioner student that we really liked that was rotating through, and I hired her to come one day a week as an RN and do nothing but chronic care. She started coming and doing chronic care 8 hours a week, making the phone calls, logging the minutes, and getting to know my patients as well or better than I did. I wound up hiring her full-time when she graduated, and when she stepped into my practice, again, she knew my patients as well as I did. And during that period of time where she was building her practice or her clientele, and typically we would have had a financial hardship while she was not seeing a lot of patients. But instead of sitting and not seeing patients, she did chronic care during those hours, and it more than paid her salary and allowed us to bring her on, and now she is so busy that we're having to bring in someone else to do chronic care as well. So more staffing, if you like more staffing, is a definite benefit. Also, since some of these patients started being seen a little less frequently, it freed up some more appointment slots. And I really like that too. I like the fact that I don't have to feel stressed seeing 30 patients a day, and I can see 25 patients a day, which I'm very comfortable with. And that was a plus for me. And then the financial rewards and or the extra time off was also a big plus. So let's talk about the financial rewards. This slide basically just illustrates the financial rewards for basic chronic care management. It does not include any of the new G code or the signing up for chronic care, and it doesn't include the complex chronic care. But for every 100 patients that you have that is enrolled in chronic care, if you are doing chronic care billing for that patient each month, if you log 20 minutes each month, you can expect to see at least $3,000, but usually closer to $4,000 a month for every 100 patients. Now, I've talked to other physicians who have 1,000 patients enrolled in chronic care. If you have 1,000 patients enrolled in chronic care, that is going to add $40,000 of income to your practice each month on the basic chronic care alone. We don't have 1,000 Medicare patients. We have a very diverse practice with children and adults and OB, and right now I have about 200, maybe 250, somewhere between 2 and 250 signed up for chronic care. And so you can still double that $4,000 amount per month, and it's a significant financial reward. And then the unexpected rewards. Well, first, chronic care is spilling over to all of our patients, not just our Medicare patients. And although we don't make the telephone calls every month to all of the patients, it's really not much more trouble for the chronic care nurse to provide the same services for other patients. And we're doing better health maintenance on everyone. One thing in my practice that has been beneficial is I quickly realized that was a wonderful model for my OB patients. And I have my chronic care nurse. She has my panel of OB patients, and she checks all of their charts each month and makes sure all of their issues are up to date as well. And the chronic care nurse actually winds up paying for herself. If you think about it, since you're required to log 20 minutes, you would think you would be able to do 3 chronic care visits an hour. It unfortunately does not work that way. But a good chronic care nurse who is very focused and sitting at her desk and reviewing patients' records and making patient phone calls can be expected to do at least 2 chronic care patients an hour. If you remember back to the reimbursement, that's about $86 an hour if they're able to do 2 an hour. And this can be done by an LPN. And so as you can see, she more than pays for herself and with plenty of income left over. And for me, the best benefit of all is the time off for the important stuff. In my case, that time often involves not having to get up an extra hour in the morning to go in and make rounds, or it may involve being able to take an afternoon off because the reimbursement is so much better. Or one of the things I've done this year is implement shared medical visits for diabetes, and that's something that I wasn't really willing to take an afternoon off to try until I knew I had revenue that I could enjoy that first before I knew if that was going to be able to pay for itself. And that has been something that has allowed me to improve my practice as well. So the time off for important stuff is very important. I hope I've covered most of the areas of chronic care, and I hope that you can tell how excited I am about it. It's something that I hope our healthcare system will keep as one of the things that is providing better service to our patients and better patient-centered care. And if you have any questions, I'm sure Karen can direct them to me as well. Thank you very much.
Thank you, Dr. Bailey. For more information on chronic care management, please visit the web pages at the end of this webcast. On behalf of the AAFP, thank you for joining us today. We hope that you found the webcast on chronic care management to be informative.